This is depression and anxiety in 15 minutes. So what is a mood disorder? Well, a mood disorder is typically defined by the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or DSM-5, which we use for all different types of psychiatric diagnoses. However, this was designed for research, and so there are nuances in clinical practice. Depression is defined as occurring over at least a 2-week period and represents a change from previous functioning, usually in different domains such as social, cognitive, occupational, motivational, or emotional. And you must have a depressed mood or anhedonia, which is loss of interest in enjoyable activities, and at least 4 of the following: sleep changes, guilt or hopelessness, energy reduction, concentration difficulty, appetite changes, psychomotor changes, or suicidal thoughts. All of these together can be combined with the acronym SIGI-CAPS, which many of you may be familiar with. Generalized anxiety disorder is a very comorbid disorder, often with major depressive disorder, but this is excessive anxiety and worry occurring more days than not for at least 6 months about multiple events or activities. This is not confined to periods when people are experiencing other mental health disorders, such as depression, phobia, and other things. And it also represents a change from previous functioning in these domains that we discussed earlier. You must have at least 3 of the following symptoms: restlessness, energy reduction or fatigue, difficulty concentrating, sleep disturbances, irritability, or muscle tension. And when you combine all of those together, this can be combined into an acronym called REDSIM. Now, we should also talk about bipolar disorder. So bipolar 1 disorder is when someone has at least one manic episode, which is when they have an abnormally or persistently elevated, expansive, or irritable mood lasting more than 1 week or requiring hospitalization. As always, it represents a change from previous functioning, and it's not better explained by other psychosis diagnoses, such as schizophrenia or schizoaffective disorders. The symptoms of a manic episode or bipolar 1 are typically defined by distractibility, increased activity, grandiosity, flight of ideas, taking part in activities that are risky, sleep decreases, and talkativeness. And when you combine all of that into an acronym, you get the acronym DIGFAST. Now, there's another type of bipolar 2 disorder. This is when you have at least one hypomanic episode that lasts at least 4 days, as well as a history of a depressive episode. You cannot have a history of a full manic episode. Therefore, if it has lasted more than a week or you've been hospitalized, you meet the criteria for bipolar 1. This also typically does not represent a change from previous functioning. However, it does have all the same symptoms during those hypomanic episodes, just differs in terms of intensity, how much it affects their day-to-day life, and duration. So why do these matter? Well, US depression rates are rising every year, and now about a quarter to a third of all people have experienced depression at some point in their lives. This is also rising in each age group, but is particularly prominent among adolescents, where we're seeing increasing rises that have continued even past COVID. When we look within children, we also see that the number of children diagnosed each year with depression is rising at really rapid rates. And so something that we need to be aware of for both children and adults. This is also aligned with higher suicide rates that have gone up about 40% over the last 20 years. And as primary care physicians, we have a responsibility to try to address this. So, how do we screen patients? For depression, we can use a simple screener called the Patient Health Questionnaire 2, or PHQ-2, that helps us ask about depression. So it's a standard set of questions that asks, over the past 2 weeks, how often have you been bothered by any of the following problems? Either having little interest or pleasure in doing things, or feeling down, depressed, or hopeless. And if you score a 3 or more, that is concerning for depression and warrants a larger conversation. Now, you can go about asking this in your own way, or you can continue to the PHQ-9, which is a larger screener for depression. If you read through all of the questions in there, you'll see that it's aligning with the SIGI-CAPS criteria that we talked about in the DSM. When you think about the sensitivity and specificity of these screeners, you can see that PHQ-2 and PHQ-9 are both very sensitive, about 90% for picking up on patients who have depression, but the PHQ-9 is much more specific than the PHQ-2. I also want to acknowledge that this screener was developed by Pfizer at the time that they were marketing a lot of their antidepressants. And so their thought process was that if we screen more for depression, we will sell more of their medications, and something we should be aware of anytime we are using a research instrument. We can also screen for anxiety using the GAD-7 score. This asks 7 questions, and similar to the PHQ-2 and PHQ-9, helps us come up with a quantitative assessment of people's symptoms. Depending on the scores, it represents different levels of anxiety and warrants a larger discussion about if this meets the criteria for a full diagnosis. In terms of the score you should think about, a score of 10 warrants that longer conversation. In the original study, the GAD-7 was about 89% sensitive and 82% specific, and it was also developed by Pfizer. So how do we treat patients with these disorders? For major depressive disorder, we typically use selective serotonin reuptake inhibitors, or SSRIs, serotonin norepinephrine reuptake inhibitors, or SNRIs, tricyclic antidepressants, or TCAs, or atypical antidepressants, in combination with cognitive behavioral therapy, CBT, and exercise. Selective serotonin reuptake inhibitors, or SSRIs, are the most common medication that we typically start with. And examples on the left are shown, such as escitalopram, sertraline, fluoxetine, citalopram, and paroxetine. SNRIs are another class of medications that are also very commonly used for major depressive disorder. This includes duloxetine, venlafaxine, and more. TCAs, or tricyclic antidepressants, are a little bit less commonly used, but are one of the original classes we began with a couple decades ago, and this includes medications like amitriptyline and clomipramine. Finally, the atypical antidepressants are commonly used as adjuncts to treat major depressive disorder, and these include mirtazapine, bupropion, and trazodone. On the left, you may notice that the confidence intervals for most of these medications overlap with each other. This suggests that any one of these medications could be an adequate treatment for major depressive disorder, and it's going to vary which agent works for each individual patient. Often we pick a couple agents that we typically use depending on the side effect profile that the patient is looking for to think about treating their condition. Treatment of generalized anxiety disorder is actually quite similar. SNRIs, SSRIs, TCAs, and CBT plus one of these drugs are the typical ways that we try to treat generalized anxiety disorder. You may also see that patients are treated with benzodiazepines, which can help sedate patients and help treat acute anxiety attacks. However, there are long-term risks of sedation and dependence on these substances, and so we generally do not recommend them as first-line therapy. So let's quickly dive into some of these classes. So for SSRIs, some examples would include sertraline, fluoxetine, and escitalopram. The common side effects of SSRIs include nausea, sexual dysfunction such as delayed orgasm, and sleep changes, sometimes insomnia, sometimes more sleep. And all serotonergic medications can increase the risk of serotonin syndrome, which is a very activating syndrome that can make abnormal vitals and hypertonicity occur and can be life-threatening. Some considerations within the SSRI class is that fluoxetine, one of these examples, has a really long half-life of about 1 week. This can be useful for patients, especially teenagers, who may not be as likely to take their medications every day. They all have similar efficacy, and there is a slight increased risk in suicidality among teens and young adults that we must counsel patients on. For SNRIs, examples would include duloxetine and venlafaxine. Some of the side effects are similar to SSRIs because there is a serotonergic component, but it also includes nausea, insomnia, and hypertension because we're acting on the catecholamine system within our sympathetic nervous system. And as I mentioned, because it is a serotonergic agent, it always puts you at risk of serotonin syndrome. One of the considerations is that duloxetine actually has very good evidence for chronic pain. And so for patients who are having mood disorders comorbid with chronic pain disorders, duloxetine is a great option. TCAs are the other major class that we think about. This includes things like amitriptyline and clomipramine. They have a lot more side effects, and as a result are not our usual go-to first-line medication. These can include anticholinergic effects like dry mouth, drowsiness, weight gain, can also lead to hypotension and cardiotoxicity, comas, and seizures. These are really scary side effects, and so we typically don't use them first line, and we avoid them in the elderly. The atypical antidepressants are other options that we have that we often use on top of the main class of medication that we might try. Bupropion or Wellbutrin is a common medication that we use. It can have side effects of insomnia, agitation, nausea, and could put you at slightly higher risk of seizures. But it's a great adjunct medication for people with substance use disorders, ADHD, and sexual dysfunction that may be caused by other antidepressants. And you can combine bupropion with your SSRIs or SNRIs if anyone is having these issues. Trazodone is another atypical antidepressant that we often use. It can have issues with anticholinergic effects, including drowsiness, hypotension, nausea, and weight gain. But the main consideration is that we actually use it at lower doses than is recommended for depression in order to help people fall asleep. It's rarely used as a sole antidepressant because the studies that have used it required such high doses that the amount of drowsiness patients would experience would often be too much of a side effect. A final atypical antidepressant would include mirtazapine. This can have side effects of anticholinergic issues and significant weight gain. It can also lead to drowsiness. Now, the main consideration we have for mirtazapine is that because it causes weight gain, it can help stimulate appetite, which as a result might be particularly useful in elderly patients or cancer patients who are no longer eating. So, how do I assess if a patient is responding to the antidepressant I've chosen? Because there are so many options, it's hard to know if what we're using is effective. So let's go through a couple different examples. Let's say we've picked an SSRI, an SNRI, or a TCA. Usually we wait 4 or 6 weeks before we assess the effect. Once it hits that 4 to 6 week mark, if a patient tells you it's not helping, they don't feel any different, just try a new agent. This could be an agent within the same class, or you could try switching classes. So again, you try this new agent and you wait 4 or 6 weeks, and maybe you get a partial response that the patient is starting to feel a little bit better, but not quite back to normal. Well, what could you do? You could increase the dose and then wait 4 to 6 weeks more and see how they do after that. And you can keep going through that cycle, but ultimately, if it doesn't help, you could always try a new agent. Now, let's say you did that partial response, you kept going through your cycles of adjusting the dose, and you get a full response, and they feel better. They feel back to normal. They're not feeling depressed. They're not feeling anxious. You should continue the medications for at least 6 months if it's their first time experiencing one of these episodes. But if it recurs, it's likely that they're going to need to continue indefinitely. And you should always consider if there are side effects and possible adjuncts that you might add on. Someone is having trouble with sleep, consider adding something like trazodone. They're having lots of sexual dysfunction, consider adding something like bupropion. So here are the major takeaways. Depression can be remembered based on the symptoms of Siggy caps. Bipolar can be remembered based on symptoms of Digfast. And anxiety can be remembered based on symptoms of Redsim. SSRIs and SNRIs are typically the first-line medication treatment for depression and anxiety. Atypical antidepressants like bupropion, trazodone, and mirtazapine can be used as adjunctive medications. TCAs are typically less commonly used due to their anticholinergic effects. And an adequate trial of an antidepressant typically lasts at least 4 to 6 weeks. Medications are also more effective when combined with cognitive behavioral therapy. So always talk to patients about medications and speaking with a therapist in order to get the maximum benefit.